Hi, everyone. Welcome to tonight's webinar. I have the pleasure and honor of being joined by this amazing speaker, Dr. Mark Blumenstein. Thank you so much for being here with us tonight. Tonight, we're going to be talking about in the blink of an eye, treating dry eye disease. Next.
Oh, that's cool that
Yeah.
you got that from.
And
Yeah.
I propose,
Look at that. Look at that's like so. Look how
I know,
pouty you
I need to
look.
work on that on Zoom.
It's almost like it's not blue steel from it's cold steel. Yeah, I like it.
Thank you. So I'm here in Miami, and you are joining us from.
I'm actually right now in a hotel room in College Station, Texas. If anybody's from Texas, get a what? Yeah, but normally I'd be in Scottsdale.
Nice. Thank you to Bausch and Lomb for exhibiting at this event. Next slide. So this is a 1 hour CE course. So for each hour of CE units, attendees must be online for a minimum of 50 minutes. For COPE certificate, there will be a survey link that you'll see there in the chat. And also the survey link will appear when the webinar ends if you missed it. CE certificates will be delivered by email and sent to Arbo with OE tracker numbers, but there's also going to be a QR code at the end of the event. So if you have the OE tracker app, you can get instant CE by scanning it with your app. It won't work with the regular smartphone camera. You do need the OE tracker app to get that instant CE. But if you don't have it, don't worry, you'll still get your CE certificate by email within 4 weeks. So you can ask questions to our amazing speaker by using the on-screen floating panel that you see circled there. Q&A is for speaker. Logistics is in the chat. If you have any questions about what's going on or any situation, you can put that in the chat. Next slide. So if you're using the mobile version tonight, you'll see it's a little different. The Q&A is going to be at the top. And then if you want to go to the chat, you'll click on those three dots at the bottom and have more options there. Next slide.
Oh, I
Oh,
think.
I will introduce our amazing speaker. Dr. Blumenstein is the Director of Optometric Services at the Schwartz Laser Eye Center in Scottsdale, Arizona, and President of the MRB Eye Consultants. Furthermore, he is the Chairman of the Education Committee for Vision Expo. Dr. Blumenstein served as the Chairman of the AOA Continuing Education Committee and served on the board of the Ocular Surface Society of Optometry, OSSO, as well as a founding member of the Optometric Cornea, Cataract, and Refractive Society, OCCRS. Dr. Blumenstein has also served as the president of Arizona Optometric Association, legislation chair, and president of the board of the Arizona Optometric Charitable Foundation. Dr. Blumenstein has delivered over 1,500 invited lectures worldwide. Wow. Served as principal investigator in over 20 clinical trial and consultants with numerous industry leading pharmaceutical, biomedical, and information technology companies. Thank you so much again on behalf of WuYu for being here and for teaching us. We're super excited to learn from you.
Well, I hope you still feel that way when all's said and done, but appreciate that. Here are my financial disclosures. Thank you, Elise. Hold on one second. Okay, that was my shout out. And all my financial relationships have been mitigated. And can somebody in the chat just tell me what that even possibly means? I have no idea what mitigated means. I don't understand it. So, yeah, it's somebody in the chat if you want to fill that in. Also, how's everybody doing? Just chat in there. Let me know how you're doing tonight. I was telling people who were offline here, I lost my wallet sometime between yesterday and today. Too much time with tap, 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 right? I feel like, what's her name? Iggy Azalea, tap, tap, tap. I don't know where my wallet is, but don't tell my wife yet. So, okay, it's all good there. If you have any questions, you can send an email to me at mblumenstein@gmail.com. And truth be told, I probably won't respond, but it's a good exercise, right? It's cathartic. You're kind of getting the question out there, putting it into the ether. It's all good. So this is not an easy discussion. And part of the reason why it's not an easy discussion is because this disease state is so nebulous. It's so kind of like just not able to kind of like get your arms around it. And I think part of the reason why, because historically, 30 years ago, If you were to say to somebody, oh, you have dry eye, they'd be like, yeah, my eyes feel dry. And you'd say, well, just, go put some drops in. Okay. And when we were in school, it was always kind of perception that there's something real, that these tears um, are actually doing something clinically when the reality is they're not. So the truth be told is that we have to redefine this disease state. So first things first, okay? I love this little graph here, and part of the reason why I love it so much is because, okay, thank you, David Hain. Mitigated, less severe, serious, painful. Yeah, but what does that have to do? Oh, you can take the money without a conscience. Okay, I like that. Yeah, yeah. So basically, it's like a CE whore. I like that. Okay, so when we start thinking about when patients come in to see us, and I want you to just kind of imagine, if you shall, patients are making appointments to see you because something doesn't seem right. Okay, the contacts feel like they need to be updated, or it's time for me to change my glasses, or you know what, I just thought it was time. And I can't wrap my arms around the fact that somebody saying I thought it was time is really their body's way of saying something's not right. And I'll give you a perfect example. Let's say you guys get off this computer or your phone, maybe you already have, and you're just waiting for it to end, and you just kind of start blinking your eyes a little bit, or you start rubbing it, and somebody sees you and says, hey, what's up with your eyes? You're like, I don't know, just they feel a little irritated right now. And somebody says, well, you need to go to the eye doctor, or you should get your eyes checked. Or one day you're driving home and there's a little more glare and you're thinking, is it my contact? Is it not? And so you make that appointment and you come in and you say something like, just here for a checkup, just to make sure everything's fine. And so what we need to do is we really need to kind of evaluate patients to determine whether or not they're experiencing some of these issues that you see on here. I don't think that you need to do everything in your practice. You can't, and you shouldn't. But the tools are there to give you the information to help you. You start asking questions like, do you ever feel like you should put a drop in your eye? Or how long and comfortably can you wear your contacts? Questions that are on here like, do your mouth feel dry? A really great question to ask patients who you want to rule out Sjogren's is ask them if they can eat a cracker without having to drink water. People who have Sjogren's just can't do it. Can't do it. Not going to do it. So, you need to basically kind of just start cajoling some of these questions out of patients. Do you feel like your vision fluctuates? Towards the end of the day, do you feel like, you see as good as you did? How about when you first wake up? Do your eyes feel as comfortable? So all these things can guide you into kind of sleuthing what's changing your patient's perception of the vision. And don't get me wrong, okay? It's easy when somebody walks in and says, my eyes feel dry. They're freaking so, I can barely keep them open, okay? That's easy. Those are wicked symptoms. Most of your patients are not on that spectrum. They have more like a dysfunctional tear. They just have more tear abnormalities. And I have a hard time calling that dry eye because to me, it's more environmental. It's more kind of like, at the moment, if you will. It's more situational dryness. And so giving patients and starting patients on an opportunity to manage that is what we need to do. You start looking at risk factors. And to me, when I see a diabetic who comes into my practice, or I see somebody who's wearing contact lenses, somebody who wants to have surgery, I start making my assessment a little bit more aggressive. Okay? Be aggressive. And why do I do that? Because I want them to get the best quality of vision, best quality of life. And the only way to do that is by knowing that patients who have diabetes, they have more inflammation. Patients that are on a lot of medications, patients that are taking glaucoma medications. Those risk factors to me say, I can't wait until the patient comes in and says, oh my God, my eyes are killing me. I need to do something before that happens. And if you take this proactive approach, if you take this notion that I'm going to see patients and it's almost, you know what? It's prove to me that you don't have dry eye as opposed to prove to me that you do. I feel like every test that you have in your practice, if you utilized it from the perspective of, well, let's look at their tear meniscus height to see if it's normal. Okay, I'm assuming it's not normal, but maybe it is. I'm going to do a Schirmer's test. Nobody does Schirmer's, but if you need 10 minutes away from your patient, let's say you have to go do a hard stool or something, boom. Or let's say you're in the middle of, season 4 of The Bear, which is coming out, and you're like, I need to go watch an episode. You just got 20 minutes, 10 minutes per eye. Okay, boom. You're welcome. I gave you that. Those tests basically validate that somebody has something or doesn't have something, is really what you're doing. So we start looking at screening tests. If it's easier for you to do like a Sandy or to do a DEQ or do one of those kind of testing, then you absolutely should do it. But when we start thinking about homeostasis markers like osmolarity and staining, those to me are ones, again, when you start seeing changes or things that just don't make sense, and so you want to rule in the diagnosis that you're basically trying to rule out. Yeah, that was a lot of double talk, but I think you guys know what I mean. And then it boils down to, what is going to be our best option here? Okay, is it somebody who has an evaporative, where we start seeing the meibomian glands aren't working as well, where we start seeing patients who are on screen time, who are doom scrolling, or right now you guys are probably doing that. You have me in the background and you're going through the TikTok or the YouTube, or you're living your best life. I see you. And that's fine. Okay, but make sure you're blinking more because we're not activating those meibomian glands. Right? We're not getting, the good quality of meibum so that these tears don't evaporate too quickly. And suffice it to say, 87% of our patients have some form of evaporative. And so we almost kind of have to roll back a little bit and say, knowing that people are doing so much of this screen time and evaporative and changing the quality of their lipids, the fatty foods we're eating, lack of sleep because we're doom scrolling still, all those things that are changing the meibum, okay, bacteria that gets on there. We'll talk about this in a second. It's like thinking about how you can formulate a plan to manage these. The aqueous deficient things with the tear meniscus height to me is quite simple. You start thinking about adding in lubricating, adding in medications that are going to do that, because at the end of the day, what this all does, as you're going to see, is it induces inflammation. Okay, and inflammation, for all intent and purposes, thank you, David, on the mitigated, for all intent and purposes, when you start creating inflammation, you create this vicious cycle. I freaking love this. This is Boudin or Boudon or Belgian. I cannot tell you how to pronounce it, but everything on this little picture here is kind of emblematic of what you deal with your patients. Look at the outside. Okay, these are all things that are causing kind of that evaporative or desiccating stress to our corneal epithelium. Think about it. The epithelium is supposed to be this nice, smooth, pristine surface. Okay, when it gets, I guess, irritated, when it gets out of whack, when we lose homeostasis, it starts overproducing something called ICAMs. ICAMs call in T cells, call in inflammation. Moreover, when you have that, you have apoptosis of the tissue, or the conjunctiva, the cornea. It changes neural tissue. The nerves then basically become denuded. They don't work as well. Or more importantly, in the brainstem itself, through that lacrimal functioning unit, it just kind of slows things down. The inflammation then causes goblet cell loss, which causes more tear film instability, which in turn causes more hyperosmolarity. So if you look in the center there, okay, everything on the outside that we talk about, allergies, contact lens wear, neurotrophic, my favorite, sex steroid hormone imbalance, boom, yeah. This is, it's nighttime. We can talk about sex steroid hormone imbalance, and for the faint of heart, okay, we're talking about hormones and other things. Okay, calm yourself. But with that all being said, we know those are those risk factors that are contributing to all of this. And where are you going to break the cycle? Where are you going to get in there and make a difference for patients? To me, as I mentioned before, a couple seconds ago, you start talking symptoms. Okay. And, you can do an OSDI, which is terrible, do not recommend it. A speed test or a DQ5 are much better, or literally just ask the same questions of patients. Do your eyes ever feel like, do they tear when you're like, when it's cold out? Okay. Do you ever feel like you want to rub your eyes? Better yet, the best question I think you should ask is, what? How do your eyes feel after you've been on a computer for a long time? I love that question. Okay. Moreover, how much time do you spend on a monitor or a computer? When we start thinking about tear quantity, okay, you can look at a tear meniscus height. This tells us the volume of the tears. And I'm not suggesting that you go out and get a device that actually measures it. And it's great if you have one, because then you have, objective measurements that you can look at patients and say, look, your TMH is low. We need to elevate that. Maybe your goblet cell density is not great. We need to put you on something like a vitamin A type of treatment. These things help. When we start looking at other tear quantity, like looking at lissamine green, this looks like exactly what I just mentioned, those goblet cells on the conjunctiva. It's one of the earliest signs of desiccating stress that's happening on the eye. Moreover, we use sodium fluorescein staining to see if we're into that damage. To me, when you see staining means this person has been dry. And my whole modus operandi in evaluating patients is to try to hit it before it gets bad, before they start having significant problems. I'm not a huge tear breakup time person because I kind of feel like it doesn't give you enough information. But if it's a really, really, really low tear breakup time, right? You play the game, let's play stare out, right? Or you have a device that actually measures it. I mean, anything under 5 is cray-cray. Anything under 10 is that kind of evaporative. If they have a high tear breakup time and I'm still seeing a lot of caca on their tears, I don't get too excited about it. So it's one of those, you can't have a false low, right? But you can have a lot of false highs. This is the way I look at tear breakup time. I don't even care about phenol red. I don't even know why I mentioned it. It's nice to have as an objective measurement, but yeah, it's really more for truly aqueous deficient. We mentioned these 4 about lubricating drops, okay? Keep in mind, a lubricating drop is meant to refresh things, okay? It's like an amuse-bouche, if you will, for treatment, okay? It's like a whiff of chocolate or just like a little mint at the end of a meal. All it does is it satiates for that few minutes, but it doesn't change anything. Now, I do agree that it's important to start and to keep patients lubricating, but I think that most of your patients are probably going and doing it anyway. A great question to ask is, are you putting drops in? Then they're self-medicating. That it's like, yeah, I feel it's important enough for me to do it. Think of all the over-the-counter products that you don't rub on your body or stick in your body or put in your eyes because you don't think you need it. But if somebody's going out and buying them, then you know what? And so what I try to do is guide them into proper lubricating drops, ones that basically maybe have, something like osmolar protection, like Trehalose, or ones that are absolutely preservative free, things that maybe have hyaluron, or even things that basically have a little bit of an emulsion to them. Because you want something that's going to last. It's going to try to keep it hydrated. But the truth of the matter is, and I tell patients this all the time, okay? And if you've heard me tell you this story, then you know what? Suck it up, buttercup, because you're going to hear it again. Is that I always tell patients that these are like mints. And I oftentimes will do my exam or do my kind of talking to patients while they're in the slit lamp, because I don't want them talking back. I'm not into this, hey, how's it going? No, I don't, I'm not, no, I'm not, I know. No, it's more like, okay, put your head in the slit lamp, shh, no talking. And as I'm evaluating them, I'm pushing on the meibomian glands. I'm like, oh, the quality of your glands doesn't look great. I think it's affecting your tear film. Your tear film, some things we need to discuss. And then I'll say, I noticed that you put drops in. I want you to think of those as a mint, okay? Just like a Tic Tac, not an orange Tic Tac, but just a mint. And then I'll say something like, and you know what, you probably could use a mint right now. Now, I usually like to keep that kind of like, a little sus because most of my patients have horrible breath. But I'm really probably talking about their aqueous, and I'm probably talking about the fact they probably get lubricated right now. But the truth is, I had a patient years ago, and this is part of my reason why I always tell the story because it's very humbling. And he said to me, he goes, dude, you love coffee. And I'm like, excuse me? And he goes, your breath reeks like coffee. And it's true. I mean, I probably drank 60 ounces of coffee already today. If you can't tell, I'm super hyper. But I looked at him and I said, that's so funny because I was going to ask you if you love dogs. Anyways, so my point in this is recommend drops that you know that are going to have some benefit for that short period of time. Don't think of these as a treatment, but think of them as a supplement to what you're doing. Okay. So with that being said, I'm highly telling you, you need to do preservative free. Now, a lot of times patients don't want to use drops. So think about a way that you can actually create a lubricating drop without actually doing something. And I'll give you a little hint. It's on the screen right now. It's called the neurostimulation. All right. This basically results in that lacrimal functioning unit by stimulating the cranial nerve 5, is that you have the opportunity to create a true natural tear. Now, we have a nasal neural modulator that we can use, varenicline. You basically spray it in each nostril. When your patient breathes, it actually creates a stimulation by basically going through the afferent, creating an efferent response. It works, people. It really does. It's, to me, using that is a first line treatment to keep the eyes lubricated for patients that just are not going to lubricate their eyes. I don't know if you've heard, but there's a new drug that was just approved. And this was accoutrement, which is from Alcon. I probably butchered it. Their trade name is Triptyr. And this is going to be a drop that actually stimulates the TRPM8 receptors. And those are the kind of temperature or cool receptor on the front of the eye. So it kind of does the exact same thing as you would with varenicline to your via, but it's a drop and it's twice a day and the results look pretty damn good. But the point to me is this, is that you're stimulating the opportunity for a patient to create their own natural tear. And if you go back and look at the lubricating drops that we talked about a few minutes ago, I mean, there's nothing real in those. There's nothing tear-like. And all of the proteins and nutrients and oils that you need come from this lacrimal functioning unit. So don't forget about neural stimulation. Another big topic, and I know that at woo you, okay? We need to come up with like a cheer. Woo, you, or something, I don't know. Woo woo. Is that there was a lid series. And if you tuned in to the lid series, I think they had somebody last week, not very good. But this lid morphology is really important, okay? Expressing the meibomian glands, looking for the demodex, okay? Looking for, apposition to the lids, making sure that there's no ectropion or entropion, misdirected lashes. So any sort of opportunity to look at full blinks, partial blinks is really, really, really critical. We're going to talk a little bit about making sure how the lid position on the eye in a couple seconds. But when you're talking also about lids and looking is think of the correlation between rosacea. When I walk into a lane, okay, I'm all about the LLPP, look, lift, pull, push. But then it's all LLPP, LD, look down, okay? Is that you can see patients, see the telangiectasia in both of these eyes, see in the upper lid, that telangiectasia, the redness, okay? Okay, Oscar, it's okay, buddy. We got you, okay? And if they give you any crap, Oscar, then use my name. It'll get you nowhere. Okay, you push on the meibomian glands, but when you walk in and see that red ruddiness to their cheeks and nose, when you see somebody who's got, just overt, acne rosacea, right? Then those patients, you absolutely should be thinking dry eye disease. You should be going in and evaluating those lids a little bit more aggressively. You could use something like the OcuStick. You know, I think there was a song by Lady Gaga about the acoustic. Tell my name about the acoustic, acoustic, acoustic. Okay. I love the Myverter that you're seeing down there. Okay, single-handed. This was from optometrist up in Toronto. The Myverter, basically, you can grab that upper lid, flip it over, look underneath there. You have your Corb evaluator. There's lots of different things, but something else that you should add into your armamentarium is when patients describe when they first wake up in the morning, they feel like their eyes are more dry or more irritated than when they went to bed. Okay, and this basically is a an inadequate lid seal. Okay, now if you look at my patient in that video, and hopefully it's coming through because I can see it. Do you see when I put the transilluminator right at the upper part of her eye? She's chill. She's like ready to sleep. She's like, dude, are you giving a talk on dry? And she's like, she's nodding off. Okay, kind of like most of my patients. But do you see the light permeating from underneath there? Corb and Blackie basically created this simple test because the lids, let me see if I can do it in the camera here. The lids should oppose each other, okay? So it's not an incomplete blink. I should do it over here. It's not incomplete. They should overlap. And when they don't overlap very well, there's this undue seal there. The air gets underneath there and causes inferior staining, causes discomfort more in the morning. So using something like a sleep type, sleep right seal, these little hypoallergenic adhesives, or using night goggles, or at the very least having them put a gel or doing something at nighttime. And this is a lot different than floppy eyelid syndrome. This is, you know, you can look at those patients and kind of get a feel for what that is. This is essentially just an incomplete lid seal. All right. Now, here's another slide that I will tell you right now that you should take a picture of. Okay. No, that doesn't work, David. Thank you for saying that, okay? Because reflex tearing, because what they've done is they've actually gone in and looked at reflex tearing for neurostimulation, and you can actually see the layers of the oil. You can actually see the fact that you're secreting meibum with a reflex tear, like a, come on, wake up. That just doesn't work. So we'll see. In the trip M8, blah, blah, blah. All right, I don't know if they're gonna be that much money, Dave, but appreciate the comments. So, everybody, look at this slide, okay? If you're not looking right now, if you're eating something, or if you're just chatting to your significant other, otherwise known as your fur baby, then what I want you to do is look here, because everything that we just talked about a few minutes ago, okay? You know, especially as it pertains to dry eye disease and meibomian gland dysfunction, is in this slide, okay? Meibomian gland, we don't blink as much. Okay, so we're getting inspissated glands, okay? Or better yet, you know, Demodex, okay, is creating, you know, more bacteria, which is causing more inspissated glands, changing the composition of the meibum through those lipases that change that. You start to get dropout, blockage. Well, that causes the microbial changes that we just talked about, okay? So you can do things like antibiotics, okay? You can do things like lid hygiene, lotilaner, lid debridement, something to get up there and clean the lids so that you can stop the progression of these lipid changes. This is when you start looking at patients and saying, you know, we need to get those glands working a little better, or I see some collarettes on your lashes that I'd like to manage. Or better yet, we start thinking that they've already got that. And this is where in your mindset, you see the changes to the meibum, the changes to the quality of their tears. You start thinking lubricating drops that maybe have an emulsion, or better yet, perfluorohexyloctane. Okay? And we're going to talk about that in a second, because perfluorohexyloctane is literally a preservative-free opportunity to stop the quality of these tears from evaporating too quickly so that we don't get more meibum lipid changes. Excuse me, we don't get an increased tear evaporation, which leads to more hyperosmolarity and apoptosis. When we start seeing injection, inflammation, when we start seeing changes that are occurring in the conjunctiva, in and around the eye, well, that's when we start thinking, you know, immunomodulating agents like cyclosporin, like lifitegrast, Okay, we start thinking things like, do I need to move into, utilizing some sort of, vitamins or supplementation to kind of change the quality of these glands? And then as you notice the decrease in the meibum, or as the meibum, basically the quality, the meibomian gland yield becomes less, then you start thinking about integrating opportunities to open up those meibomian glands. So what this slide should do for you is it should open up your mind to the fact that there's a plan, okay? I'm Team Kendrick, okay? But Drake's got a plan, okay? Not a fan, not a fan. But, and for my Canadian friends up there, I'm sorry, but, gotta say, Team Kendrick. But my point being is that when you look at this here, it basically gives you an opportunity to see where each thing integrates into how your patients are starting. That symptomatology, you're doing some of your testing, but now you're thinking they're on the computer a lot. We're seeing a lot of meibomian gland changes. I need to supplement with some tears, but at the same time, I also need to decrease the evaporation, change those lipids. If I start seeing injection, I need to add an immunomodulating anti-inflammatory drop as well. So those things all go great, okay? Now, with that also being said, is that, this doesn't mean you do everything. This doesn't mean that you throw the kitchen sink at all of these patients, okay? But this does mean that you can try to define your diagnosis and define how you're going to manage these patients, okay? Coming up with a lid lash strategy, okay? As we mentioned in the last lectures, and I'm not going to, I'm going to go through it relatively quickly, but we have a new approach and a new opportunity when we start thinking about, Demodex, right? We know that there's both follicular, which is in the follicles, but there's also brevis, which colonizes in the sebaceous or the meibomian glands, okay? And knowing that they carry with them a unique bacteria inside them called Bacillus olearum, is that we're creating more lipases and changing quality of our meibum. And so a diagnosis of Demodex blepharitis is also concomitantly managing the potential or the exacerbation, the comorbidity, if you will, of meibomian gland dysfunction. Because these little buggers basically, are mechanical. They scratch at the eyes, they open them up to infection or irritation. They bring in inflammatory mediators. They create chemical kind of changes to the quality of the follicle, but also think about them doing that in the meibomian glands, right? They leave behind the collarettes as your diagnosis. So every one of these patients that you see on here is the Demodex blepharitis. But look at the other thing you notice. Do you see all the redness? Do you see the injection, the rosacea, the misdirected lashes? And these are all common components of things that we see in dry eye disease. And when you diagnose dry eye, right, you're thinking quality of tears. Quality of the lids kind of produces a large amount of those tears. We talk a lot about evaporation, okay? And it focuses on the lid, right? Because we know through Korb and Blackie that 86% of these patients, or actually I think it was more Lemp who came up with, the statistics demonstrating that about 86% of our patients have some form of evaporative. And we can't get past it. We're not. You know what? Everything we do in our life right now is on a monitor. It's on a tablet. Younger kids, your mindset of this disease state, okay? When you think about it, this blink of an eye, it's the blinking that's not happening, which is causing so much of the grief that we have. And I know, drawing everything back to patients and giving them about what's in it for them, or I don't feel it. I always like to think of quality of life, okay? And to me, quality of life is being able to open up your phone, your computer, your tablet, and be able to sit there and binge Reacher. I mean, you know what? Or whatever show you're watching, okay? Maybe you just heard about White Lotus. Piper, no, Piper, it's you want your patients to be able to do that. And so to me, managing that should be what we think about. I mentioned this briefly, but it's like the lipids, aqueous, mucin deficiency, all of these things can induce evaporative stress. because they change the quality of your tears, which induces that desiccation, inflammation, tissue damage, and it's a vicious cycle, but that environmental changes is so important. You have a treatment, friends, okay? And that treatment is perfluorohexyloctane. And what perfluorohexyloctane, otherwise known as MIBO, what this does is it creates a protective layer on the cornea. Now, on the tears, I should say, not the cornea. I love telling patients, you know what the side effects are of some drugs going to be. And the main reason why is because when I can tell them what the side effects are, then they don't think that they're, something that they should be concerned with. It's an expectation. Now, with that being said, I love better to be able to prescribe something that patients say, I didn't even know it went in my eye. Or better yet, you don't even have to worry about it. The beautiful thing about perfluorohexyloctane is that it is in a bottle that basically is preservative free because it doesn't have water, so it doesn't need preservative. Nothing grows in there. It's literally just perfluorohexyloctane. 14 chain carbon, you see over there, 2, 4, 6, 8 of these are fluorinated. Is that 6? No, 6 of those are fluorinated, okay? And then 8 of them are carbon hydrogen, okay? Now, with that being said, your hydrocarbons basically enjoy being in kind of the water, and your semi-fluorinated ones like to be in the air. So it just creates this monolayer, okay? And that monolayer just sits on top of there. And that's all this drug does. And when I start thinking about how we've reestablished who our patients are that we need to start treating sooner, I start thinking about your kids. I start thinking about my kids when I tell them something about, watching TV and they go, what's that? Because all they do is watch YouTube. Or my son who built a computer when he was in high school with his friends and they stayed up all night gaming, okay? And he'd come out in the morning going, Dad, my eyes are killing me. And they were beat freaking red. And I'm like, stay off the ganja, bro. And he's just like, I don't do that. It's like, no, he doesn't. He just sits there and nerds out on the computer. So I look at younger patients and I'm thinking perfluorohexyloctane is going to manage those patients. And they had 2 really large clinical trials. 100% of the participants had clinical signs of MGD. And the bottom line here is they demonstrated clinically significant improvement in corneal fluorescein staining, as well as in eye dryness scores, which is really, really important because that basically says patients are noticing a change. The bigger thing here is that 90% of patients feel that this is extremely comfortable and tolerable, and they love it long time, okay? Here's a good example of what it looked like in the study, okay? At baseline, their total corneal fluorescein staining score was about a 7, okay? Central fluorescein staining was about a 1.1, but just as we go through here, day 15, okay, day 57. See the differences in the staining? To me, staining means steroids, means inflammation. So the fact that we're able to reduce some of that inflammatory load means a lot. Now, we have a lot of other interventional treatments, okay? And what I mean by that is that you establish the lids, okay? You work on your patients with the lids, as we talked about before. You might want to use, moist heat masks. Watch out for patients with rosacea because that just heats it up and exacerbates it more. Talk about the expression, talk about blinking more, utilizing some of those drops that we talked about, especially like perfluorohexyloctane for the evaporative aspect, for the MGD. But for the inflammatory and for the aqueous deficient, you need something that's going to help increase tear production. And so for that, you got to start thinking of things like cyclosporin, okay? Levitigras. Okay? Cyclosporin comes in many different, treatment options these days. You have your generic Restasis. You have your, which is 0.05% cyclosporin. 0.09% is Cequa, which comes in the nanomicellular. And then you also have the 0.1%, which comes in the semi-fluorinated alkane vehicle, and that's from Harrow. What the beautiful thing about cyclosporin is that it's demonstrated that it reduces inflammation. It reduces the production of the T cells. Moreover, it slows down the progression of your inflammatory mediators. The challenge, though, is that cyclosporin hates being in water. Okay. And so you need to cajole it. So you need to make sure that the vehicle you're using works really well. So you see signs of inflammation, then, going to something like a cyclosporin is definitely going to benefit your patients. Okay. Where's my lifitegrast? Oh, there it is. Okay. Topical steroids, yeah, it reduces all the inflammation. I told you before, staining means inflammation. But if you have patients that have like a seasonal kind of like dry eye, where it's like, oh, my eyes get really red, irritated, much like people who have asthma, where it's like sometimes throughout the year they get asthma that bothers them a lot. Okay, episodic dry eye, there's a low dose Lotamax, lotopradnol, which is called Isuvis. So it's lotopradnol 0.25%, works really great for those patients. So don't forget about just managing it by giving them something to treat on demand. Because there's going to be days. You know what? I lost my wallet today. My flight got canceled this morning. I had to drive in a car for 3 hours. Yeah, it's been a day, you know what I'm saying? And so my eyes are probably bothering me more. Now would be the time I would want to use something like that. Give your patients that tool. Where does lifitegrast fit into this? It is the only medication that has been engineered specifically for the eye. Okay, so it has both signs and symptoms. In their clinical data, it's demonstrated that it works faster than any of the other immunomodulating agents. It's been around for a couple decades. There's been 5 clinical studies. So what's nice about lifitegrast or Xiidra is that you have an opportunity to do something a little bit different, okay, a little bit unique, right? This is the only one that basically creates a blockage of those. I told you the ICAMs are overexpressed on the epithelial tissue, and literally what it does is it just puts a cap on it and it blocks it, okay? Boom, okay? It's kind of like Gandalf in Gandalf the Grey in Lord of the Rings, where it's like, you will not pass, you will not pass. And if you don't know that reference, sad, okay? So you don't have the interaction between the LFA1, which is on the T cell, and docking with the epithelial ICAMs, inducing more T cells. Not only does that, it doesn't draw more T cells in. So it kind of has a unique opportunity there. Something else that I really, tell me what you want, what you really want. I want you to start thinking about as adding into your armamentarium is amniotic membranes. Okay, if you have Medicare patients, and I'm talking to my not cool North American friends up there, but down here in the States, if you have patients that are on Medicare, then these patients are approved to be used for an amniotic membrane. So if you start seeing signs of increasing staining or avert signs that you don't see a lot of symptoms for, or if you have that recalcitrant kind of dry eye that's not working well with some of the other treatments you're doing, immunomodulators, anti-inflammatories, then jumpstart them with an amniotic membrane. The dry forms are a good way to start, especially for patients that just have more of a dry eye. They're relatively inexpensive to your practice. You don't bill for the membrane itself; you just bill for the insertion. Okay. Now, commercial insurance is a little harder, but when I have patients that have erosions, okay, and then they come back and their eye still feels dry or irritated, then you know what? I'm Johnny on the spot with an amniotic membrane. When I perceive or think they may have a neurotrophic keratitis where the dryness has gotten a little bit more progressed, then I will put these patients on there. So any form of like central staining, think about an amniotic membrane. Have them in your practice, okay? Autologous serum is that next go-to, okay? We talked before about the fact that lubricating drops are caca. Okay, because they don't have anything in it. Your own natural tear does. That's why neurostimulating to kind of get some of those lipids and proteins and nutrients and all the good stuff that we want. Well, all of that's flowing through your plasma. And so for me, for patients that have really, resistant dry eye where the treatments just don't seem like they're working well, I've done my lid therapies, I've traveled through, all the different options with these patients. I have autologous serum in my back pocket, okay? And what's nice about it is that you have it spun out, you put it in there. It's not terribly expensive. I know that somebody had brought up expense, for a lot of these patients who are really symptomatic, That is true. Thank you, Glenn. It could be. Thank you. Although I had it, Glenn said it's under my car seat. That is so funny though, because it was before I left here to come here, Glenn, it was under my front seat. But then here's the irony of it is that I didn't have a car. So yeah, I'm traveling. Thanks though. Appreciate you, buddy. Is that you just have patients go, they draw the blood, they spin it out, they take the plasma, they get 3 months worth. And for a lot of patients, they feel that this is a lifesaver. So, add this into your armamentarium. Now, when everything doesn't seem right, when the signs and the symptoms don't match, okay? When it's really just not dry eye and you've been managing, much like we started talking about Demodex, where that's not really dry eye, but it makes dry eye worse and it can induce dry eye. On the other side of the spectrum is patients that come in with just crappy looking eyes, just terrible, terrible eyes, and they don't know it. They think it's blurred vision, or they may have mild symptoms, okay? Oftentimes neurotrophic keratitis is not no symptoms, but it could just be milder symptoms. And so we need to basically be conscious of the fact that we want to use something like a synergism, okay? Or otherwise known as oxyrvate. But before you even do that, start with an amniotic membrane, okay? Balance it out a little bit, okay? Maybe even put them on some autologous serum, because oxyrvate to me is something that takes a little while to get. I absolutely think you should, be prescribing it, but sometimes it just takes a little longer to get it into your practice, okay? Now, I'm throwing this in here a little bit because this paradigm shift, when we start thinking about some things, to kind of rolling you backwards in this dry eye disease state, okay? This was a study that was done by Josh Johnson, and I like the study because it changes your thought process. And in this design phase of the study was patients that were on Restasis who weren't doing well, okay? Best corrected vision, had to be, better than 2200, but their Sandy score was greater than 40. Excuse me, they had central corneal fluorescein stainings. They had tried using Restasis and it just didn't work. So what he did is he switched them and put them on Cequa. And I bring this up because I think that we get pigeonholed into thinking, okay, well, 0.05% cyclosporin is the same as 0.09%, which is the same as 0.1%, which is the same as lifitegrast, and it's not, okay? And much like what you would do with a glaucoma patient who is on latanoprost, you know that not all generic latanoprost work very well, right? You wouldn't move them out of a prostaglandin class, you would just switch it. So in this, he basically switched them, and the beautiful thing of this was he saw a statistically significant improvement in total corneal staining, and he saw that as early as 4 weeks and continued on for 12 weeks. He noted that patients had stated that they felt their eyes felt better. You see there's an improvement in the Sandy score, which is clinically significant. He noted that there was changes in patients' visual acuity, and also patients just liked it better. So this paradigm shift should be, don't stop using these medications, okay? Start with your go-to, right? If it's something like lifitegrast because, the coverage is great and because it's unique, and then a patient starts saying, well, I don't really feel like this is working for me, don't say, oh, well, none of these work. Switch them to another one, okay? Or start with one and then, move to a different class. But think about the fact that the vehicle in these medications also contributes to the treatment. And so I avoid generics as much as I possibly can. Now, this paradigm shift when we start thinking about thermal pulsation, right? Heating and massaging to the lids, unblocking those. Would it not be great, okay, if like a dental hygienist, we could bring these patients in every 6 months and go, boom, we're gonna do this. Well, this notion of inflammation and obstruction kind of work hand in hand as you go back to the very beginning of this talk, where I mentioned about the evaporative stress and how it causes desiccation and how we really need to kind of control both the meibomian glands as well as the inflammation. And we think about all the things we're doing. Okay, well, there was a study that was recently done, and you see my name on there, patting myself on the back a little bit, you're welcome. But part of a clinical trial for side sciences. And this was the attempt here was to demonstrate that by just opening up the meibomian glands, by using intelligent heat to basically melt the glands, to be able to get us to express those, that for a lot of patients, that is equivalent to reducing the inflammation to something like a restasis. Now, why did they pick restasis? So in this randomized controlled trial, okay, cyclosporin ophthalmic emulsion for the treatment of dry eye, what the goal here was to do a treatment, okay, and then start patients on restasis. So one arm started on restasis and one arm had one treatment. Brought them back at 5 months and did another treatment, okay, and then we evaluated all these patients at 6 months. So it's 6 months. So it's 1 month from their last treatment, and it's 6 months of being on restasis. And literally what was found in this was that basically the patients that were on restasis, their Sjogren scores was equivalent to the patients that were on the tear care product. Patients had a greater tear breakup time, okay? But then in the patients who did the tear care system, and lastly, it was non-inferior to patients' symptoms. So the bottom line here is that it worked as well with symptoms and as well as Schirmer, but the tear care procedure increased the meibomian glands secretion, and more importantly, their tear breakup time was better. The goal that they have right now is to go to payers, third-party patient access, to say to the insurance companies, instead of spending 6 months worth of, drugs, what if we did something in our practice and you covered that and covered that at a level that was commensurate with a really good relative value unit for this. So they're working on that right now. And I don't think it's a Hail Mary. I think that our study demonstrated that it does work. And so imagine how your practice, this paradigm shift would be in your practice if you were managing these meibomian glands and the insurance coverage for patients allowed you to do it. I think it would be a game changer. I really do. And here's the study design, primary endpoint, too much there, okay? There are other devices and things that you should think about doing in your practice, especially as we think about the progression of dry and the management. And I bring them up because, one of our biggest challenges, friends, is that, yeah, we're friends, okay? So if somebody types in there, we're not friends, yeah, we are, is getting patients to be adherent to what we're asking them to do. And I always love to, kind of like shine the light on the fact that I live with a dry eye patient. She has Sjogren's, she's in her 50s, she's light-skinned, she's had LASIK surgery 20 years ago. I mean, you could not Frankenstein this dry eye better than this person. And if anybody ever says that I called her Frankenstein, I will cut you. But she doesn't do anything. It's like literally she has at her disposal every single treatment option, okay? She's heard from the best minds. She's listened to people like Elise Kramer and Mila, and Paul Karpecki talk about, dry eye and how to manage it. But what does she do? Nothing. And every time she has an exacerbation or an irritation, she'll say to me, Mark, what should I do for my eyes today? They're really killing me. And I'm like, well, those drops? She's like, you know what, whatever, I'm not using them, okay? Which one should I use? To me, even the best of patients don't stay adherent to what we want them to do. It's kind of like your Peloton bike, okay? Yeah, right? Start riding it again, right? You just lose adherence. But imagine if you did things in the practice, if you did them while they were sitting there, that they don't have to be adherent to them anymore. So something like low-level light therapy, right? Or something like intelligent heat and expression on the glands. Something like intense pulse light, like our friends here at Selena McGee. I mean, what these do is they can reduce the inflammation, okay? They can open up the meibomian glands with that evaporative stress. They can still use recovery drops. They can still use other types of medications, but they won't be as completely dependent on them. And this is where, even if you don't do these in your practice, find an OD in your area and do inter-optometric referrals. Have them do it. Get them involved and be able to do it. When you look at IPL, the beautiful thing, and these are Selena's patients, is that you go from that really kind of red ruddiness, the neovascularization, it cauterizes it, and it decreases the inflammation that's going to the tissue. I mean, look how it basically just makes everything pop and feel better. Yeah, I get it. You're probably not going to be able to sell somebody on dry eye therapy, but you know what? They're going to look good. When you think about chalasia treatment, incision free, you can do, IPLs, but also don't forget about managing the Demodex for these hordeolum treatments. Okay. Look at this guy with his IPL. Boom. Super exciting. Okay. I think that was his mugshot. He just got arrested, but you didn't hear that from me. Okay. Look at that one treatment with the IPL. Look at it the next day. Okay. Pretty good. Pretty good. So, I love mentioning too, real quickly, about meibomian glands, that Laura Perriman came up with this BESTO, that when you think about MGD, it's bugs, enzymes, inflammation, stasis, temperature, and obstruction. And somewhere along your management of this dry eye patient is you have to get in there and treat these. Okay. Lastly, I'm going to end on punctal plugs. Why? Because this is the last thing that I would do. It induces inflammation, and I get it, but if I'm going to put a plug in, that I want one that is not going to be in there permanent, and that's going to be intracannulicular. There is a new cross-linked hyaluron that basically fills into the cannula and basically goes through the puncta. Lacrophil. It's phenomenal. It's beautiful. If you're going to do a plug, then do something that you know is going to be able to be removed from there. Okay. And then I will leave the scleral lenses to next week because, there's a talk on that, I believe, if I'm right. I think I am. But just, what? Don't let your patients go and just manage themselves, okay? Give them options. Do a step-by-step approach, as we just talked about, and pause and ask yourself, did I miss something? But better yet, start with the notion that every single patient has dry eye, and work backwards from that to prove they don't. And I guarantee you, there's not a patient that's going to come in your practice that you're not going to think I need to do something different. This is my time, friends. I wasn't lying. Look who you've got. You've got Dr. Brooke Messer and Jamie Kuznier and Zach. Look at, we're doing Scleral Lens Summit next time. That's June 29th. I know there were some questions in here. Are you going to ask me them, or are you going to...
Unless you want to go through them, but there's so many questions.
Why?
So little
Why do you have so many questions, people?
Do you start patients with a steroid for 2 weeks at the same time as
I do
cyclist?
not. I am not one of those people that does the old Schleppian study of rolling people in, because we know it works. If I see staining on the cornea, then yeah, I'm going to prescribe them a steroid. Central staining, I'm going to prescribe it. But aside from that, I don't think you need it. Do you, Elise?
I don't. I'm not one of those people either. I like steroids for other things, but
Yeah.
not for, cyclosporin. Um, do you
Marcia, don't ask me any questions about IPL. Ask Elise. Okay? Elise, you answer the IPL questions. I'm throwing it out there saying it should be used, but Elise, do you use the dry eye filter to treat chalasians?
Yeah,
And
I do.
yeah,
I do. Yeah. Yep. Do you notice most patients with Demodex have pets? I notice that in my practice. How else can patients attract Demodex in their eyes?
okay, so the reality about Demodex is this. Demodex in pets is Demodex is scabies. So scabies Demodex is something completely different, but that's where lotilaner came from. But the Demodex mites are basically in dust. So it's almost kind of like a dust mite, but it's so permeable or so pervasive on the skin, the neck, the head, that literally patients get it. And I had this patient who was a dentist. He was an 82-year-old retired dentist, Elise. And I told him, I'm going to be honest with you, you have a lot of debris. It's a lot of built up carcass, feces. It's all these little dead mites. I said, and truthfully, you probably got it there when, your mom was breastfeeding. Oh my God. The guy called up. He was so put off by the fact that I talked about his mom suckling him or something. I'm like, dude, chill. You're a dentist, okay? Calm yourself. But to whoever asked that question, yeah, that's the reality. That's where they come from. And
Thank you so
yeah,
much.
we've
That
reached
was
our
amazing.
time.
I know. I wish we had more time for fun questions, but I learned a lot. There was so much action on our Q&A and chat, and thank you for, doing that as we went along. So we've concluded our CE portion of the evening. Thank you again to our wonderful speaker, Dr. Mark Blumenstein. You are amazing.
Thanks, guys.